Hey everyone, it's Adam Farkas from ODwire. Thanks so much for coming out again tonight. Now, tonight we have a really interesting webinar for you. It's always fun when we get to talk about new technology. You know, sometimes in the webinars we talk about clinical stuff, sometimes we talk about practice management stuff, and in this one we actually have a new instrument to discuss, talking all about early detection of glaucoma with objective pupil testing. And I can't think of a better person to do it than the guy who we have here tonight. So Craig Thomas is an OD, as everyone knows, in Dallas, Texas, and he has been at the forefront of technology throughout his career. He runs a big private practice in Dallas. And the most notable thing about him, besides the fact that somehow he keeps up with all this tech, I have no idea how he does it, is that he likes to keep on the cutting edge. So what you're going to hear tonight is all about the cutting edge of this objective pupil testing. Now, before I turn everything over to Craig, let me just remind people who are watching live right now, on the right side of your screen, you'll have a control panel. If you have any questions for Craig, just type in the question box, and I'll hold the question aside, and we'll have a little verbal Q&A at the end. Two other housekeeping things. One was about the little raffle that we're doing, the ODwire raffle. We're going to go over that at the end of the show as well, if there's time at the end, so we'll announce a winner. And the other thing is Conan wanted to let you guys know that they're offering a special for folks who show up for the webinar. And at the very end of the show, we'll go over what that special is and how you can take part in it. So with all that said, why don't I turn it on over here to Craig. So Craig, thanks so much for being here tonight.
Thank you, sir. Glad to be here.
So let me turn this over to you and we can get it started here. So and again, if anyone has any questions, I can sort of see already that people people are starting to ask as they usually do. Again, feel free to put it right in that box that you can see on the right side of the screen, so you can ask questions there. Okay, so Craig, you should have control of the system, and you can take it away.
All righty. Good deal. All right, everybody. Good evening. Good evening. Welcome to ODwire, early detection of glaucoma with objective pupil testing. Fortunately, this is not a CE class, so we can kind of be fast and loose. I'm not going to say anything strange, but we don't have to be too strict, so I'm going to just kind of have at it. Let us proceed. So what we're talking about tonight, and again, I wish to thank everybody over the past week that looked at the thread that we started on the website about a week ago, where I started talking about this technology and the patients that I'm seeing. Several days ago, it went over 1,000 views, which I always consider a pretty significant benchmark. That means people are looking, people are reading, people are talking. For it to get that much attention, I mean, it kind of hit a nerve somewhere. So I was real pleased with that, and I think it's good, for all of us to get this information, and we're going to keep it going tonight. So what we're going to start talking about, we're talking about testing pupillary reactivity. It's kind of a comical thing. Adam and I were talking right before we started, and he says, Craig, how do you think most guys and ladies check pupils, when they do this stuff now? And I started laughing. I said, man, based on my investigation, when I talk about this in classes, and I'll ask the assembled doctors, hey, what kind of pupillary testing are you doing? If I've got 100 docs in the class, there might be 2 people that raise their hand and say they actually whip out a transilluminator or a pen light and do it for real, like they taught us in optometry school, doing it back and forth, doing it in a dark room, all that kind of stuff. Yeah, maybe 1 or 2% is my experience when I was lecturing about this technology at Vision Expos and such. So I think it's a good time to revisit it, since most of us don't appear to be doing it. And the last time we actually did it was probably in some clinic in second-year optometry school. Those guys that have heard me speak before, you know that I'm loath to read slides. Everybody can read the slides. We're looking at them now, so I'm not going to read slides to you. Everybody can see what's going on. The main thing is just as a quick refresher, remember what we're supposed to do is whip that pen light or transilluminator out, go back and forth, do the swinging flashlight motion. Somehow, supposedly, I'm supposed to have my eyeballs calculated down into 0.2 millimeter steps, and I can tell if one pupil is 0.5 millimeters bigger than the other, or one is going faster than the other. It's almost nonsense to even talk about it, to where the human eye could pick up relatively fine differences in pupil responses. What you're supposed to do is, if you see a difference, one pupil to the other, you're supposed to whip out the 0.3 neutral density filters that everybody's got sitting next to their trial lens kit, and then whip that neutral density filter in front of the eye and try to balance the pupil response going back and forth. I think the last time I did that was in 1980. If anybody is still doing it, good for you. What we're going to start talking about is doing it a better modern way of testing the pupils. So let's keep going. I got to figure out these controls here, Adam.
There you go.
There we go. Yeah, help me out. Okay, there we go. Okay. Yeah, I got lost there. Now, as a refresher, we all have to have our base science to really understand stuff. And we all learn this and we all know it, but it's worth spending 1 minute refreshing ourselves on the pathway of the pupillary light reflex. We all kind of familiar with the visual pathway, starting with the eyeball and going all the way back to the visual cortex. The pupillary light reflex starts off with the same anatomical pathways going from the retina, the optic nerve. You see the whole pathway here with these yellow the lines here. The big thing about the pupillary light reflex is that the neural response goes to the midbrain right in here, this Edgar-Westphal nucleus area. And remember all that stuff from my neuroanatomy, and then circles back. So the pupillary light reflex does not go past the midbrain. So those signals don't get to the lateral geniculate nucleus. They don't go to the visual cortex. So if something is wrong with the pupillary light reflex, if your pupillary reflex testing is abnormal, then the defect is somewhere in here. It's in the optic nerve, it's in the retina, it's in the tract, it's somewhere over here, it's in the midbrain. It's somewhere in here is where you got to concentrate looking. Okay, so that's kind of an important differential most of the time when I'm ordinarily talking about visual pathway stuff. I'm talking usually going from the very front to the very back. With the pupil, you're going to stop in the midbrain. Okay. Now, why would we do this stuff? Why would we, other than because we're supposed to, and that's how we're trained, from a just a real sincere point of view, why are we doing this? Why are we testing someone's pupils? Because if they have a significant pupillary defect, it could be a clinical sign of any of these conditions that you see in these colored circles. In my experience, glaucoma is the most common. Multiple sclerosis is the second most common. These two right here, that's what I see almost always. Just as a matter of information, 3 weeks ago, for the first time in my 36-year career, I actually ordered an MRI of the brain with a concentration on the midbrain. I had never said that once before in my entire career. But this lady had an abnormal reading on the pupillary testing, and I couldn't figure it out. And so I actually said, hey, go look in the midbrain. I'm looking for something that's messing up her pupillary reflex. So the reason we're doing all this, because if we find something wrong with the pupillary reflex, it may be an indication of one of these things, which is all kind of pretty important. And you see that the title of this thing is, trying to find some glaucoma with an abnormal pupil. We're going to get to it in a minute. And again, glaucoma is the most common one that I have seen. And I've been doing with this technology. It's new, but I had the original version of this technology called RAPDs, and I found lots of patients with lots of problems with that technology too. This one's just much better, faster, easier to use. Now, this slide here on optic atrophy, I put this again just as a refresher, because most of the time, what we're looking for, what the pupillary reflex being abnormal is telling us, is that there's some type of optic atrophy somewhere in that pathway. Now, I put this picture up here where you see the entire visual pathway going from the eyeball nerve all the way back to the visual cortex. And again, the pupillary stuff stops here in the midbrain. The regular visual stimulation signals go all the way back. Again, you see the little tidbits of information there on optic atrophy. You guys can read that. And remember, optic atrophy is kind of a general thing, and there's 10 things that could cause it. So you got to figure out which of the 10 things it is. That's why we make the big money, is trying to figure out which of those 10 things it is in those circles. All right. So optic atrophy is kind of, the holy grail of what the pupillary reflex being abnormal is telling you. There's some atrophy somewhere in that pathway. You got to figure it out and find it. This is a picture of the device for those people that haven't seen it on the ODwire thread. So this is an EyeKinetix device. It's called a pupillograph. It's non-invasive, non-contact. It's real simple, real easy. And it produces a printout that gives you a RAPDs score. And the general sense, I mean, everybody's different, so you can't have absolutes, but in a general sense, scores above 0.3 may be considered abnormal. What I do in my own practice is if I have a 0.3 is my cutoff, because again, you go back to the original science, the 0.3 increments in the neutral density filters. You know, the 0.3 is the starting point for the neutral density filters, you know, 0.3, 0.6, and so on. So if you need at least the one filter to normalize or equalize the response, that would be considered clinically significant. So that 0.3 is our starting point to consider, you know, people that may have something wrong with them. So this is what the instrument looks like. It sits on a table. It's real light. It's easy. Now, this is the case that I put on ODwire. And everybody that's listening tonight probably read that thread and saw what I talked about and how, you know, the lady had glaucoma and all the stuff that I talked about on that thread. So quickly, I'm gonna just go through it for those people that maybe have not seen it. And to me, this is a demonstration, and that's what I put this up on ODwire for. Is I wanted to just present and demonstrate the technology, show people what an abnormal reading is, and show people the associated findings that would correlate with that abnormal reading. So this is the one that I put up on ODwire. So we'll bust through it real fast. So, you know, this is a relative afferent pupillary defect case. So you see the 48-year-old lady comes in, she's real myopic. I've seen her me and my partner go back and forth seeing her. And she's been coming here for 8 years. When she came in 3 weeks ago, those were the pressures, 28, 23. So, you know, she's suspicious when I shook her hand. I did my RAPDs, and she was a 1. The RAPDs score was 1 on her. I don't know if I blanked through it there just a second ago. Okay, so there we go. Here I did my nerve scans. Again, if you saw it on ODwire, you saw this, you know, obvious fallout of the retinal nerve fiber layer, both eyes, severe loss. Visual fields, you know, the horrendous fields, you know, make your toes curl. You know, this lady's lost more than 50% of her vision in her right eye. You see the mean deviation, minus 19.7. And the difference in mean deviation correlates with the RAPDs score. So that's the RAPDs score, the mean deviation on your threshold visual field, and your nerve fiber layer thickness. Those 3 variables all correlate science-wise. And if you see one being off, you should expect to see the others being off. So you'd have to decide, do you want to do a threshold visual field? Do you want to do an OCT scan? Do you want to do an objective pupil test? And they all may show you similar findings, which I think is good. Here's the latest score. So this was the patient's RAPDs score. You see right here the 1. So, you know, there's a 0 in the middle. So here's the right eye, the left eye's on the other side. You see ODOS. So the right eye has a RAPDs score of 1.00. That is extremely high for someone where you don't know that they have a disease. Like I've seen 2.5s and stuff already with people with multiple sclerosis. But, you know, a 1 on somebody where you're thinking they're okay, that's going to catch your attention. I found these little factoids here, kind of curious. For most people, you need a 27% or more difference in nerve fiber layer thickness to start to produce the RAPDs abnormality. You know, there may be some people in here without an OCT. You know, this will give you a clue. Okay, it'll give you a clue at half the price. So that's what the score looks like. This is what the printout looks like. You've got all these waveforms. You can get deep into it. We're not going to do that tonight. Mostly I just look at the RAPDs score and I move on. So that was that demonstration patient where I just wanted to show you with a lady with you know, what I think is bad glaucoma. I was going to take Scott Cahill's advice and try to go vascular and make sure she didn't have some kind of event. I haven't done it yet, but I still think she has glaucoma until proven otherwise. So that's the demonstration case. Okay, so you can see how, you know, if you've got a patient that has a 1.00 RAPDs score, they probably got a pretty funky looking visual field, and they got pretty funky looking OCT scans. Okay, so that's, I'm going to start to expect to see that correlation from now on going forward with my patients. So now let's pivot a little bit. We've kind of talked about pupillary reflex testing. We've talked about the neural pathways of the pupillary response, the neural response. talked a little bit about a demonstration about, hey, if this lady's this bad, what does this particular test look like? So we kind of got that out the way. So now let's keep going. I'm on a big thing here the past year or so on subclinical disease. One of the classes that I'm going to give next year on CE Wire is on subclinical disease detection and how do you deal with that? How do you find it? What do you do about it? So I'm real big on subclinical disease. I think it's a growth area for us if you understand what you're trying to do and have the technology to do it. It's really amazing if you kind of just broaden your perspective on trying to find stuff wrong with people. So subclinical disease, as a refresher, hopefully, I looked it up in the medical dictionary, and I'm not going to read it, but it's basically, it's something where it stays below the surface. Another way to look at it, it doesn't have any recognizable clinical findings. So it's hiding, it's low key, it's subclinical. So subclinical disease, that's the definition. Now, you see this other stuff I've got here where I start listing the service components of an ophthalmologic exam as defined by current procedural terminology. So if you go and get a CPT code book, which is what we should all be going by, because that's what we go by, that's what the insurance companies go by. If you go by the CPT code book, as opposed to going by optometry school stuff, an eye exam is made up of these things here. It's not made up of refraction and any kind of chaining and checking and all of that stuff they taught us 80 years ago. This is an eye exam for most people, these things right here, okay? So you do these things right here, and it's called an eye exam according to the CPT code book. So let's say I examine somebody, you examine somebody, we're all examining somebody tomorrow morning, and for us, an examination is an ophthalmoscope and an occluder. Okay, I can do a comprehensive exam 92004 with an occluder and an ophthalmoscope. I don't need an occluder. I could use my hand. I could put 3 fingers up and cover somebody's eye up. I don't need technology to do the patient history. I could do this. That's just me looking at them. I could do this with my fingertips. I probably would have caught that other lady if I'd have done it. I could do this with a pencil tip. I could do that with my naked eyes. I could look at her with my naked eyes. I don't have to do biomicroscopy, but I should. And you have to do ophthalmoscopy. All I need is an ophthalmoscope, and I could do a 92004, $155 Medicare payment exam all day long. That is a clinical examination. Okay, that's a doctor doing a clinical exam. If you're doing a clinical examination and you determine a diagnosis, it is called a clinical diagnosis. And you see the little factoids right here where they equal that. So clinical exam, clinical diagnosis. And the key thing, a clinical diagnosis is one that is determined without the benefit of diagnostic test or procedures. No test, no gonioscopy, no procedures. It's me and my ophthalmoscope, okay? That's a clinical exam, and I got a clinical diagnosis. I have diagnosed people with advanced glaucoma with an ophthalmoscope, period. No pressures, no nothing, okay? Pressure got nothing to do with glaucoma. Everybody that knows glaucoma knows that. I have made a clinical diagnosis of glaucoma with an ophthalmoscope, and I know I'm not the only one that's done that. So as a refresher, clinical exam equal clinical diagnosis, okay? Well, that's not really what we want to do too much. What I want to do is a physical exam, and I want to determine a physical diagnosis. And you see the difference. Look at the picture here. It's me with the same lady kind. So here I am showing this lady. I got these big screens in all the exam rooms. The patients love it. So I'm showing the lady her OCT scan. Well, I ran a test. See that's a physical diagnosis right now. If I go to this, which looks almost the same, okay, all I'm doing is showing her her fundus photos. To me, I don't count fundus photos as a test. All I'm doing is taking a picture of what I just looked at. It's a better picture, but I'm just taking a picture of what I just looked at. This is not a test. This is part of my clinical exam. And if I see something here, right there, okay, I'd have seen it with my ophthalmoscope, so I can make a clinical diagnosis of diabetic retinopathy. Here, I'm running tests, physical exam, physical diagnosis, okay? Big difference, big difference, big difference, big difference, big difference. And y'all see the little bullets there. So what is subclinical disease? Again, I don't want to read the slides, word for word, but y'all see it there. So subclinical means I might need to run some tests to see if you got something wrong with you. Okay, that's what a subclinical disease means. It doesn't mean that the problem is insignificant. It doesn't mean that there's not a loss of function. It just means that the regular stuff that we've been trained to use, like an ophthalmoscope and an occluder, are not sufficient to figure out what's wrong with this person, especially if it's early in the natural history of the disease. That's a big deal. For most of us, for most patients, the presence of subclinical disease is a risk factor for regular disease. Okay, so you got to, if you find it where it's hard to find, okay, it'll be easy to find next year. I could just wait for you to go blind a little bit more, or we could try to find it when it's early. So the measurement of subclinical disease, and again, this is almost like we're in school and you got the nice optometry school professor and everybody's falling asleep in class 20 minutes in, and the doctor stops and says, test question, and everybody perks up and starts taking notes. If I'm reading slides to you, it's like a test question. Measurement of subclinical eye disease requires non-traditional thinking and modern technology. That's what it requires, y'all. So let's keep going. Let's get non-traditional and modern. Now, if you remember the thread on ODwire, and I said, what is it? The raging glaucoma detected with my EyeKinetix pupillograph, my second case. This is the first case. This is the one. I am hooked like a crackhead, hook, line, and sinker on this technology. You couldn't pay me to give this thing away now. If I find one guy like this a month, I'm going to be so happy I won't know what to do. So let me show you what I found 3 weeks ago with my EyeKinetix pupillograph. So this guy comes in, regular guy, one of my friends. I went to college with this guy. I've known this guy for 35 years. He's a professional person. He ain't poor. He's not a knucklehead. He's physically fit, perfect plano vision, wears a 2-ad. He just can't read. He comes in every year, does his superior vision insurance, gets a pair of glasses. I say, see you next year. Okay, it's every year. So this guy comes in 3 or 4 weeks ago. Okay, he comes in for his regular exam. So you see his there. These ain't the best pictures in the world, but they're good enough. I mean, I don't see any obvious cupping. There's no temporal pallor. There's no rim law. I don't see a lot. There may be a little something there, kind of. I mean, there's not a lot going on there. There's clearly not a lot going on there. If you say there is, I don't see it. Okay. So now, part of our workup now is to measure the pupillary responses objectively with this EyeKinetix device, and you see the device being used right now. So that's a picture of us doing the guy on an instrument table. It's hands-free. You stick your head in it. It takes about 60 seconds. It's pretty cool. The lights kind of flash. It's a really cool experience, actually. I thought, and totally easy. So here's the patient taking the test. Okay, so he finishes, and then the way I work it in my office, all the preliminary testing is displayed up on these big screens, and it's sitting there available to me when I walk in the room. So the patient's sitting here waiting on me to come in. I come in. If there's anything of significance, some kind of weird finding that the staff has generated, they have enough training to put it up on the screen to where it's the first thing that I see when I walk in. They know that right now, the first thing that's on the screen for practically every patient is the RAPDs score. Sometimes it's a topography map, sometimes it's an OCT scan. It just depends. Right now, almost always, it's a RAPDs score. So I walk in the room and I see this printout on the screen right there. Now, I'm not pointing at it like I'm doing now. This is at the end of the exam, but it's sitting up there when I walk in the room. So I walk in the room. I'm not going to freak out and spook the patient right at the beginning and mess up the visit and get him all scared. So I'm gonna go ahead and do my thing. I'm gonna do a refraction. I'm gonna chit chat and do my stuff. And at the end, I'll kind of turn to him, and I'm pretty smooth with it. I've done it a long time, and I'm real good at it. And I'll say, "Hey, man, I got good news and bad news. The good news is you still got 20/20 vision, man. You see like a hawk. Your vision is great. All you need is these reading glasses, these no-line bifocals. They'll take care of that. So we strong as onions right now, and it's all good. The only one thing is I've got this new technology, and we're checking everybody's pupils when they come in now, and your pupillary reflex test was a little bit abnormal in that right eye, and it's right at the cutoff, and you see me pointing to it now. So I'm into my spiel. I got my thing going now. I'm like, man, it might be nothing, or you might have glaucoma or a brain tumor. Now that's a pretty wide range, and I did it on purpose. Okay, it's a Jedi mind trick. Let me say it again for you. Hey man, I got some good news and some bad news. Good news, you see great, but there's this one little thing here. It might be nothing. It might be nothing, but you might have glaucoma. Man, you might even have a brain tumor. Man, I don't know. Uh, you got a few minutes, so we can make sure nothing's wrong with you. Is that okay? Yeah, doc. Yeah, sure. Whatever you say, doc. Man, I'm good at it. Okay, that's how you do it. Okay, that's how you do it. So that's what I did. That's what I did. And so he said, yeah, I got a few minutes. So I said, well, let's go down the hall. And in my office, the first test, 99% of the time, is an OCT scan. OCT scan of the retina. Takes 5 minutes, gives you so much information, maybe 7 minutes, but it's so much information. Okay. So I do my OCT scan. This is what I got on my nice OCT, OptoView OCT. So you see here the right eye, nerve fiber layer scan, optic nerve scan. You see the whole superior half is abnormal. Okay, you got some sector plot defects there. So I'd say right eye, that thing's not normal. If I go to the left eye, it's totally normal. The sector plots are normal, everything looks fine. You go over to the ganglion cell. Look at the ganglion cell analysis on the right eye, man. It's totally jacked up. Something's wrong. That's not cool. Look at the left eye. It is totally normal. I mean, like a kid, like a 20-year-old kid. It's perfect. This is perfect. This is messed up. Well, that's clinically significant asymmetry. Clinically significant asymmetry is a common finding in glaucoma. Now, that doesn't mean he has glaucoma, but that is a common finding in glaucoma. So now I've got a guy that appeared to be perfectly normal, okay? Perfectly normal. Let me go back. Perfectly normal. Pressures are 11. I've seen this guy for 20 years. I went back through 20 years of records. His highest pressure in 20 years was 15 in one eye. In 20 years, highest pressure was 15. It's never been below 10, never been above 15, man, in 20 years. So look at this close up on the ganglion cell. This is atrocious. I mean, this is atrocious. If you did some kind of double blind study thing and somebody just whipped this print out in front of you and say, hey, do you think this guy's got something wrong with his eye? Yes or no? Well, the answer is yes. Okay. The answer is way yes. Yes. So, pretty big deal here with the ganglion cell. Look at this Tisnet curve profile. Look at the left eye following the normal double hump distribution. See the trace. There's the hump like it's supposed to. Everything's in the green. Look over here on the right eye. Man, he's in the red. The slope is all depressed right here. It's all in the red there. This is like two different people in a guy with 20/20 vision, equal looking optic nerve appearance, pressures of 11 in each eye. Okay. All right. Let's look at it. Let's keep going. So I ain't finished. So I keep going. So I did my structural analysis. All that stuff was structure. Now I want to do function. If you want to see if somebody got something wrong with them, you do structure function analysis, period. You evaluate the structure, you evaluate the function, you put them together, and you figure out if somebody got something wrong with them. I think this guy got something wrong with him based on my structural analysis. What I want to know now, does he have a corresponding loss of visual function associated with those structural defects that I picked up with the OCT scan? My first test of visual function, which was the pupillary testing, was abnormal. Objective pupil testing is a test of visual function, no different than color vision, no different than visual fields, no different than ERGs, no different than VEPs, no different than dark adaptation, no different than contrast sensitivity, no different than visual acuity testing with a refraction. So I did 2 visual function tests on this guy before I did this stuff. The first was the pupil test. The second was the fraction. One was abnormal, one was normal. I'm split down the middle. I need more information on functional vision. The first thing is color vision. His color vision is normal. Hey, good for him. I'm glad. Go to the next one. I did an ERG designed to detect glaucoma damage, the photopic negative response, all this stuff right here. It is totally normal in both eyes. Good for him. I did an ICVEP. I know a lot of guys don't have it, don't know what it is. Okay, some of us do. In my opinion, the ICVEP is the most sensitive electrodiagnostic test for glaucoma. And this guy, again, I'm not going to get into the trying to interpret it. Just trust me. Everything on here is abnormal, and it's abnormal in both eyes. Like this guy's got glaucoma in both eyes. That's what the VEP test told me. The ERG test said he was normal. The color vision test said he was normal. This said he was abnormal. Well, I got a visual field up here too. What's going on with that visual field? Oh wow, visual field test, right eye. This is a guy with a pressure of 11, 20/20 vision. So here, fixation losses 0 out of 16. Man, I think he figured out how to do the test, because this is the second day. I did one on 10/15. That's when he came in first, and he didn't know what he was doing. So I made him come back the next day and do it again. And this one was accurate. So you see glaucoma hemifield test outside normal limits. Look at all these these shallow paracentral scotomas right down here inferiorly. Okay, remember what we saw in that ganglion cell. Just go back to the basic science. Basic science. Right eye, left eye. Superior structural defect, if it's real, will produce an inferior visual field loss. Like right here, that's what I'm seeing. Superior hemifield is normal, inferior hemifield is abnormal. You go to the left eye, the glaucoma hemifield test is within normal limits. It is outside normal limits on the right eye. Significant difference in the mean deviation. This is clinically significant asymmetry that correlates with the clinically significant asymmetry found in the objective pupil testing, that correlates with the clinically significant asymmetry found in the OCT retinal scanning. Man, I got 3 things matching up. I'm almost there. 1's not enough. 2, I'm thinking about it. 3, I'm usually pulling the trigger and telling somebody they got something wrong with them. I think this guy has glaucoma based on these test results. So I told him that. I said, hey, bro, I think you got low tension glaucoma. He's like, I'm denying, he went spiritual on me. He said, I'm denying it. I said, man, okay, you deny what you want. These tests suggest that you have low tension glaucoma in your right eye. I recommend that we initiate treatment with Combigan, and I see you back in 2 weeks. He said, we ain't doing none of that. Okay. I said, fine. Okay. So he said, well, I said, what you want to do? He says, what's plan B? I said, plan B is me looking at it 6 months from now and starting over. He says, I'm down with that. We could do that. He said, he's one of them health guys. He don't want to take medicine. He don't want to do nothing. And he said, there's nothing wrong with me. I feel fine. I said, bro, look, come on. I'm not making this stuff up. You're not normal. He says, I feel fine. I see great. I want to get some glasses. I'm like, okay. So, I let it go. And I mean, I can't make the guy do nothing. And I said, look, I think you have glaucoma. He says, I don't think I have glaucoma. I said, okay, fine. Then I'm not going to put that in the record. I'm going to put partial optic nerve atrophy. I said, because I know you have partial optic nerve atrophy. I think it is glaucomatous, but I don't know that yet. I'd have to wait to see for it to progress. So I just said partial optic nerve atrophy, and you see what I did. Okay. Now, let's get to a little bit of fun part, since this ain't no CE class. Let's talk about a little money, okay? Because you got to make a living, and there's nothing wrong with making money as long as it's legal, ethical, moral, and medically necessary, like it is right here. So this is the correct way to do it. If anybody, I know I got a little junior reputation. People think I'm out here just trying to do stuff. I'm trying to help people. That's what I'm trying to do. And I'm trying to make a living while I do it. And there's absolutely nothing wrong with that, okay? If I had to make stuff up, if I was stealing, if I was scamming, okay, that's different. This is real. So here's how you do it properly, with all the rules being followed, all the I's dotted, all the T's crossed, okay? So you got an eye exam. The guy came in to get a pair of glasses. He didn't come in because he thought he had glaucoma. He didn't come in because I told him he had a jacked up pupil. He didn't come in for none of that. He came in to get a pair of glasses. And we all know, going to all of the seminars, that the chief complaint drives the reason for the visit, not what you find. You can follow those rules if you want to. I don't care. For the purpose of this presentation, we following the rules. So the rules are, he came in to get a pair of glasses and he had no complaints. Well, he got superior vision. They pay me $52 for exam. He got a $10 copay. That's what he came in for. I don't have no problem charging it. That's fine. I could have charged this United Healthcare for the exam and made another 30, 40 bucks. I don't need to do that. It's not that important. You'll see in 2 minutes why it's not that important. So the guy comes in, and what you're not seeing on here, of course, is he actually bought a pair of glasses too. So he dropped a few $100s on some glasses. So he comes in, he gets examined, superior vision, $52. I reported the examination to superior vision, diagnosis of presbyopia. Now, I got my abnormal pupillary reflex that I determined on preliminary testing. So when I walked in the room, I'm looking at the abnormal pupillary reflex. It's part of an exam. You've got to do the pupillary reflex testing anyway from a medical legal perspective. Now, whether you do it or not is up to you. It's no different than any other thing that we're supposed to do. If you don't, you can fill out ophthalmoscopy. You don't have to do it. You could be unethical if you want to. But most of the time when we say we do stuff, we're doing it. So I don't have a reason to do any testing other than the abnormal pupillary reflex that I got on preliminary testing, the objective pupillary testing. I spent 30 minutes looking up United Healthcare local coverage determinations. I went into every Medicare carrier's local coverage determinations. I went to Blue Cross's website. I checked 4 or 5 people, the insurance payers, and comically, in a perverted negative way, not one single payer pays for diagnostic test with a diagnosis of an abnormal pupil. So this guy could have a relative afferent pupillary defect. The diagnosis code is H5702, something like that. And that'll generate an exam all day long. You can see the guy every day for a year with a diagnosis of abnormal pupil. You just can't generate any test with it. So if you put abnormal pupil as the diagnosis, they won't pay for an OCT scan. Those things don't go together. So I did not have any, there's no medical necessity for me to run any test with a diagnosis of abnormal pupil. So any testing done with that as the diagnosis, or that as the driver, or that's the medical necessity component, that test technically, ethically, legally, supposedly is an out-of-pocket screening expense to the patient because you don't have medical necessity to run it where they're going to pay for it. So in a technical sense, that guy would pay out of pocket for the OCT scan. I charge $50. You can charge whatever you want. No kind of fee collusion. Do it for free. Do it for $100. I don't care. Whatever. I charge 50. That's why I put that there. So I'm expecting this guy to pay 10. I'm expecting him to pay 50. Yeah, okay. He's got money. He's working. And then once I did the OCT scan, now it's on. Okay, because you saw the OCT scan. Once the OCT scan was abnormal, I can do whatever I want, as often as I want, anytime I want, day or night, weekends too, whatever. Okay, once that OCT scan was messed up, it's on. Okay, it's the gold card. I'm on. So now visual field, color vision, ERG, VEP. Some people say, how can you do a VEP? Because I don't know what's wrong with it. Why would I not do a VEP? Why would I intentionally withhold technology that I got sitting down the hall that might help me figure out what's wrong with this guy? I mean, that makes zero sense. I don't know why people talk like that. If I had dark adoptometry, I'd have put it right here too. I'd have done everything. The more the merrier. I'd have done enough until I could figure out what was wrong with it. Now, if I could figure out what was wrong with him in 2 tests, then I would stop. That's the ethical way to go. But if I needed 4 tests, I'm doing 4. It's and again, I'm just starting. Why would I do 2 tests and stop when I got 4 sitting down the hall? Let me figure this thing out. And again, look at the difference. Look at the difference this EyeKinetix made from a practice management point of view. I already talked about the clinical benefit. I mean, it's off the chart. But I was on the verge of seeing this guy making $52 for an exam, making the incorrect diagnosis by telling him that there's nothing wrong with him when there is something wrong with him. I'd have said, see you next year, got my little $52, and I'd have rolled on to the next patient. He'd have come back next year. I might have figured it out then, and he would have been my most recent case of raging glaucoma, which of course is the glaucoma that you did not diagnose at the patient's previous visit. So here you got $52 versus $460. Okay, you make the call. I mean, I've made my decision. You guys know how I practice. 52, 460, 460, 52. Correct diagnosis, incorrect diagnosis. Good care, better care. It's your call, but this is how it is in my office, and I'm just trying to expose what I do, good and bad. You saw a little bit of the bad on the thread. Here's all the good. So that was this guy's first visit. I told you the visual field that day, that October the 15th, it was totally messed up. It was just a waste of time. As I looked at it, I said, man, we did go to college together, so I know you got sense. You can't do this test right. And he just looked at me. I said, all right, tomorrow morning, come back. And I wanted to check his pressure again tomorrow too, the next day. So he came back the very next day. He came in after work. I did an exam because I had to check his pressure. There's the diagnosis, relative afferent pupillary defect, H5702. So that was the reason he came back, okay? All right, those are what I get paid. He paid it. He has a $30 copay, so he got real good insurance. I took some photos because I didn't bill for the OCT, so according to the insurance, this is the first, imaging. I repeated the visual field. I can repeat the visual field. Okay, there's nothing wrong with that. It's not my fault that he couldn't do it. Okay, so I repeated it the next day. Then he came back when he picked up his glasses. So I saw him like on Monday. Then he came back on Tuesday. We made his glasses. When he came to pick up his glasses the next Monday, then we checked his pressure again. The highest it was 14. I did a corneal hysteresis on him. His hysteresis value was pretty high, so I felt a little bit more comfortable. And I said, hey, man, I'll see you in 6 months. And I'm going to start this process all over again, brothers and sisters. That's what I'm going to do because that's what's required to render top-notch care. Now, last case, we got 10 minutes left. This one is not glaucoma. Yeah, so again, to me, what I've seen, glaucoma is the number one, multiple sclerosis is the number two, and then this kind of weird stuff here is my number three. And I have one of these today. I did. So this lady comes in. I'd seen this lady before, not a lot, but maybe 4 or 5 times over the past 10 years, so she comes every couple of years, gets a pair of glasses. There wasn't really nothing wrong with her, some dry eyes. So she came in on October the 9th, okay? So she comes in and she says, I said, what's up? What can I do for you? You need some glasses? She says, no, I got something else going on. I can't see good out of my right eye. There's something wrong with my right eye. I said, well, okay, fine. My staff has measured your vision. You see 20/20 in that eye. She goes, yeah, but something's wrong with it. I said, well, tell me, what do you think it is? She says, well, I had these seizures in the summer, and they put me in the hospital for 2 days and did a bunch of scans and stuff, and they couldn't find out what was wrong with me, and it hasn't been the same since. And the neurologist and everybody thinks I'm crazy because they can't find anything wrong with me. And I go, okay, all right, maybe you're crazy. I don't know. Who knows? So now, and again, I'm looking at this 0.69 RAPDs score the whole time I'm talking to her. It's sitting up on the screen. So I'm listening pretty attentively because I'm like, okay, well, hey, I don't think she's crazy because I see this 0.69 RAPDs score. That tells me that her pupillary reflexes are abnormal. That strongly suggests there's something wrong somewhere in the neural conduction pathway of the pupillary light reflex. I mean, that's what that suggests. So I'm like, okay, hey, let's see what's going on. So I start running some tests because that's what I do, run some tests. So here's the first test. The first test is always OCT. It's always OCT. So look here at the OCT. So you got, pretty normal on the right eye for the nerve, the nerve fiber layer, the Tisnet curve profile is looking pretty good. This little yellow, to me, that's not clinically significant. The left eye, same thing, on the gross sector plots, everything's green. You got the one little quadrant defect that's almost nothing. All your statistical analysis is green. Everything is green. I submit to you, brothers and sisters, that many of us would stop right now and say, there's nothing structurally wrong with this patient's nerve or retina or any of the stuff that's being measured with this OCT scan. You have to do the ganglion cell. You have to. The test is incomplete without doing the ganglion cell. They go together. It's like, milk and cookies, okay? Look at the ganglion cell. And I've seen this before. I don't quite know what this is yet. If somebody knows, when we finish, y'all type it in. But I've seen this on many patients. I don't know what it's some kind of optic atrophy. Look at this red ring here. Look at that ring. That is abnormal. That ain't right. Okay, it's in both eyes, right there. That ain't supposed to be there. Look at it. Okay, it's not. If we go back to the first patient. Look at his right there. See, that thing is totally green. There's no red ring around. That's what it's supposed to look like. Okay, right there. So even though the regular nerve fiber laser scan is pretty normal, so the nerve fiber, but the ganglion cell is absolutely abnormal. That is a clue. My very first test shows some structural abnormality. It's not bad, it's not crazy, but it is there in a lady having seizures out of nowhere, hospitalized for it 6 months ago with no previous history of any kind of nonsense like that, okay? I think they're related. I think it's a clue. So I have evidence, 2 things. I've got an abnormal pupillary reflex in the right eye, and I've got evidence of optic atrophy. Remember that slide on the optic atrophy? That's why I put it in there. I've got evidence of optic nerve atrophy on both eyes as demonstrated by my ganglion cell complex analysis. So I'm on the scent. I'm on the scent. I'm on it. So now, has she lost any vision? She says she can't see right. Visual acuity is 20/20 in each eye. Threshold visual fields are normal in each eye. Color vision testing, sophisticated, computer assisted, top of the line, can't be no better. Nagel anomaloscope comparable color vision is normal in each eye. Electrodiagnostics, VEP was normal. Looky here, this is the first one. So I did the ERG with the photopic negative response. And here it's a little bitty thing, but it's a little tiny bit abnormal. Okay. I mean, she ain't going blind or nothing, but you know, how come it's not all green? It's all green right here. This one's all green. That was normal. Okay. You know, either you're pregnant or you're not. This ERG is abnormal. So I have an abnormal ERG. I have an abnormal pupillary reflex response. I've got an abnormal OCT, and I've got a lady telling me subjectively there is something wrong with me. I cannot see clear out of my right eye since I started having these seizures in the summertime. And I said, well, let's start over. I said, I believe you. That's the first thing. You ain't crazy. And she almost started crying. She says, none of my doctors are believing me. They all think I'm crazy. My neurologist won't do any more tests on me. They think I'm making it up trying to get on disability. I go, no, 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 no. I see it. I see the optic atrophy on the ganglion cell. I see the abnormal pupillary reflex. I see the ERG. I believe you. I think something happened to you. I don't know what it is, but I believe you. I started all over. I ordered MRIs, MRAs, Doppler ultrasound of the carotids. I did the whole shebang. Everything was normal. Everything was normal. And I called her in and told her, I said, hey, girl, you're looking pretty good here. I said, you don't look like you get ready to fall out, but I believe you. Okay. Because I had three things that were abnormal and something made that ganglion cell turn red. Okay. Something made it happen. I don't know what it is yet, but something made it happen. I've now had 3 patients in the past 6 weeks with almost identical presentations where they have seizures, have an abnormal RAPIDx score, and I can't find out what's wrong with them. It's weird. And so I put this in red. If anybody got the answer, y'all answer it when we finish. Do seizures cause brain damage? If you're having seizures, can it damage some kind of soft tissue stuff in there where you can't pick it up on an MRI or anything else, but I can pick it up with that EyeKinetix. Okay, I can pick it up with the OCT. Everybody's different. So to me, this was an interesting case that's not glaucoma. I got a bunch of these coming now. I mean, it's almost every 3rd or 4th day we're seeing a patient like this. And I didn't put any kind of practice management or money slides on the others because it's always the same. Okay, it doesn't matter what you think is wrong with them. You're going to do a structural assessment and a functional vision assessment. Whatever technology you got, you're going to max it out every single time. That's how you evaluate patients with abnormal pupillary reflexes. That's how I do it, and that's how I'd recommend you do it. So that's a non-glaucoma case, which again, I'm almost starting to get more of these than people that I'm getting suspicious of glaucoma, where I rule out glaucoma, but they still have abnormal findings. So in conclusion, objective measurement of the pupillary reflexes will enhance your ability to detect a relative afferent pupillary defect, and it'll help you identify. I mean, you still got to work, you still got to do it. Okay, these machines are not automatic. Nothing is automatic. Nothing is perfect. There's no perfect OCT. There's no perfect visual field machine. I've already had a couple of docs where they would kind of private and say, "Hey, man, if this thing is, it's not totally reliable, is it worth it?" And I'm like, "Are you serious?" And so that means you're not going to buy an automated threshold perimeter because sometimes patients can't do the test. So you're not going to test anybody because somebody can't do it. That means you're not going to do threshold perimetry because some people have funny responses. So that means that everybody's responses are nonsense, and we're just not going to do that test anymore. Why? Well, we can't be unfair. You can't put standards for one technology, that's different from another technology. No technology is perfect. This thing is cool and it works almost all the time. And I have made many decisions already with it. And again, without sounding mercenary, I've made some money with it, and I don't feel bad about that because I'm working for it. I'm helping my patient. I'm finding subclinical disease that I would have missed. You know, the raging glaucomas, the undiagnosed multiple sclerosis, the weird seizures. I mean, just the list is growing. The list is growing. So I would encourage everybody to consider adding this technology to your practice. If you have most or all of the other technologies that I talked about tonight, the ability to pay for this thing is almost automatic. I mean, you find 1 or 2 patients a month and you'll generate enough extra fees to pay for the device. If you just want to be ethical and moral and clinical, you're going to deliver better care. You're going to find more problems. You're going to help people. That's what we're supposed to be doing. The more people I help, the more money I make. I like it like that. I like to help people a lot. Okay, I like it a lot. The last thing, you know, on the website, there was a few docs talk about, well, I could do an OCT scan and figure out if somebody's got this stuff too. Yeah, maybe not. You know, an OCT scan is not part of your exam, whereas pupillary testing is. OCT scanning is going to take 5, 6, 8 minutes. This is 1 or 2 minutes. You know, over a day, we're 3 doctors in my practice. We see 100 patients a day. Okay, 5 minutes times 100, man, that's kind of a big deal. So you're going to do 100 people on a pupil test. You're going to do 100 people on an OCT scan. Okay, yes, your call. I'm telling you what I do and how I do it, and I hope it's helpful to some of us, and you could use some of what I talked about tonight to your advantage. So I think I'm done. Adam, are we done?
All right. Well, Craig, thank you so much. This was really fantastic. So the questions are coming on in. So let me pull them on up here, and you know, we can sort of maybe you know, there's many comments, actually, comments and questions. So let me
Okay.
forward the slides here a little bit. So again, if you want to ask a question, just use the question box on the right side of the screen. And we can go from there. So let's see. First of all, an observation here, which is pretty funny. In that last case,
Mm-hmm.
one thing that was interesting was this patient had asymmetry, right, in the pupils, but was under the
Correct.
care of neurologists. How did the
Yes.
neurologist miss that? Were they just doing swinging flashlight tests?
I believe strongly that the neurologist has already dismissed the patient internally, you know, from the mindset. So the neurologist is not listening to the patient anymore. So the neurologist, he's already dismissed her, you know, to where she can complain or say something. He's thinking she's crazy. And so he's not really trying to process it and give her any kind of legitimate options.
Right,
That's what I think is going on.
right. And
And
then,
and number two, honestly, uh, you know, again, I don't have any neutral density filters to be checking what this machine is doing. Uh, you know, what if it's too small to see with the naked eye? You assuming somebody could see a 0.69 with the naked eye and whip out some neutral density filters to balance it. Okay, maybe, maybe not. He might have
right,
checked it and thought it was normal.
right.
He might have checked it and thought it was normal. That's what I'm thinking.
Yep. And a question here actually related to that last one. Since you're starting to find so many neurologic issues, do you ever work with a neurologist?
Yes, I have 2 of them that I work with, and they like me. I like them. It's all good. So the answer is
Right.
yes. And mostly who likes me the most is the imaging center. They like me a lot.
Sure. So that's an interesting question to go along with this. Do you have to actually educate the neurologists on what this new technology is when you send them over the reports?
No, it's almost like trying to educate the primary care doctor about OCTA technology. So just skip over it and just go to the scans and just give them something they can understand. If the
Right.
scan is normal, like this lady here. So let's say I called up her neurologist. I said, hey doc, you know, we got this mutual patient. She's been having these seizures that you're treating her for. You know, she's still not seeing good out of that one eye, and some of my test results are abnormal. Is it possible for you to revisit your diagnosis and kind of start over? Man, all I'm gonna hear is a click. Okay.
Right.
Yeah, none of that's gonna happen. So
Right.
my job is to help the patient deal with the neurologist. Okay, you know, that's my job. Almost to help the neurologist. That's my job.
Right.
Okay. Yeah.
One interesting question here is, what if the nerve damage is symmetric in patients? Would you be able to pick any of this up?
Well, that's a good question, and the answer is yes. The third case was symmetric with the ganglion cell. They looked identical almost, but you had a very significant asymmetry with the pupil test. And the patient's subjective complaint was asymmetric, where she said, "I can't see good out of my right eye." I mean, that's pretty strong to me.
Right. Yep. And question here, you mentioned the test is pretty quick. Do you use technicians for this, or do you do it yourself?
Oh, I don't even know how to turn the thing on. I mean, that's no. You got to remember who you're talking to now. All I know is how to interpret the results and how much it costs. Okay,
Right.
I don't run notes. I can't, man. If I didn't have a staff member, I could work a Goma tonometer, but I can't do that eye care. I can't. I don't do. I walk out the room when they bring a new machine in. If I got to run the machine, it's the end of the world. And when my staff starts looking at me crazy, like I was like, I say, okay, well then, if I got to go in there and run that test, you come in here and do this exam. Okay, switch if that's what you want. Okay, you
Right.
do what you do, I do what I do. You run the machine, I give instructions. Okay, so I can't run them. I don't know how to do it. It don't look
Right.
hard. Yeah,
Yep.
I
Question.
got girls who were selling hamburgers 2 months ago. They're doing it. So it can't be too.
So not too difficult.
Yeah,
Um,
yeah,
so related question, in terms of false positives, have you seen those come up?
yeah. I'm starting to see those, but it's not false. It's just unknown. See, the
Hmm.
terminology is wrong. I believe something's wrong with the patient. It is not a false positive. I just can't find out what's causing it.
Right.
Whole different way of looking at it.
Right.
So
I
so
mean,
what I
what's
so look at the lady that we just the lady with the 0.69. Okay, if that ganglion cell had been normal, I'd have been puzzled. Okay, I'd have been almost clueless if that ganglion cell would have been normal, because then all I would have had was that one slight abnormality on the ERG. Okay, so again, let's say I do a patient tomorrow morning. Her RAPIDx score is 0.5, totally abnormal. I run every test I can. Does that mean there's nothing wrong with her, or does that mean I just haven't found it? Which one does it mean? Who makes that decision? Who gets to call it a false positive as opposed to an undiagnosed problem?
right.
So false positive implies to me that the machine is faulty. I don't believe that.
Right.
Not
And I
after two
guess,
months.
I mean,
Yeah,
in your case, of course, you have so many different diagnostic tests at your disposal too, right? It
exactly.
seems,
Yeah.
you
So I
know,
mean, if yeah. So to me, if I run 7 tests on somebody twice and all those tests are normal, and the only thing that was abnormal was the pupillary reflex, I might go there and say
right.
that's a false positive. But I would have to go through that level of comprehensive evaluation to then go to that as my last diagnosis as opposed to the first. So when I see a high number, the first thing I'm thinking of, hey, what's wrong with him? Not, hey, is that a false positive? I'm not going to get to the, hey, is that a false positive until 3 weeks down the road, when I'd have checked everything twice.
Right. So, observation here, you're picking up subclinical disease. How do you explain this to a patient? So, let's say that you're picking up something that could be MS that hasn't really expressed itself yet. How would you even explain that to a patient that this is, something that they should probably look into?
Well, I mean, it's again, every patient's different, but in a general sense, I say, hey, Miss Jones, it's kind of like I did the little show and tell thing before. Hey, Miss Jones, I've got some good news, bad news for you today. The bad news isn't too bad, but one of our tests came out a little bit abnormal, one of the pupil tests, and a lot of times when that test is abnormal, it indicates some kind of neurodegenerative process going on in the person's brain. You might be fine, but there could be something going on here. I did not have this technology at your last visit, so it was impossible for you to make this kind of really, really early diagnosis. Now that I have the technology, we can really see what's going on much, much earlier. And now I can see what I've been missing since I've got this device. And now I know exactly what's going on. Most people will buy that and they won't challenge you or think any less of you for not having picked it up earlier, especially in this scenario where they clearly know, especially if it's a returning patient, that they did not go through that test before. So
Right.
the fact that I say, hey, I got a new machine, and my patients, it's a running gag in here. You said it earlier. I mean, I tell you, man, the top 3 referral reasons that people get sent here by word of mouth, which is still my #1 referral source, is because we run lots of tests on people. People come here when they got problems because they know we'll figure it out. That is our reputation. This is a spaceship up in here. Okay, we got machines in every corner. I got machines in the bathroom. Okay, everybody walks in here. They know if something's wrong with them, we're gonna figure it out. That's what they
Right.
come here for, and they tell me that. They'll say, Don Thomas, man, I never had an eye exam like this. Man, you got all these machines. I ain't never seen nothing like this. I don't even know what to say, man. This is just incredible, just incredible. Hey, and the good news is ain't nothing wrong with you. That'll be $400, please. Okay.
Right.
Yeah.
So
So I
funny,
mean,
it's funny, we just got a couple questions, and the same question from several different people. So how often do you have your techs redo the test if you think that they're getting a false positive or an unusual reading? Do you have them ever redo it?
Yes, I do, but not hardly anymore now because it's always the same. And I right at the beginning, I did it a lot, and they were always close. I mean, I never had a patient where one was a point 0.3 and the next one was a point 0.9. It's
Right,
never like that. The machine's good.
right,
Uh, you got about maybe a 5% spoilage factor where the eyelids are so droopy it keeps messing them up, or their pupil, or there's actually something wrong with them and their pupils don't react very well. Some real old person, something like that.
right.
But I mean, it's less than 5% spoilage factor. So I mean, if I did 100 people, 95 of them I'm going to get good readings that I trust. I would challenge anybody to say anything different on any other technology. If you did 100 people on a visual field and you got 95 of them that you thought were good enough to make decisions, and that ain't good enough, okay, you're being greedy. So the false positive thing, it's there. Okay, I already told you how I feel about it. The only time I'm gonna put false positive in the record is after I've tested them on every machine I got twice, and it's all normal. Okay, then I'll say, okay, you might have a false positive here.
Right,
That has not happened yet. Okay.
right.
The few that I've done where I couldn't make a decision, they're just coming back in 6 months.
Yep,
Because if there's something wrong with them, if it's progressive, then something will be different. And
right,
it'll be easier for me to make a decision.
right. So we're running out of time, but one final question here. You've used the older technology as well to objectively measure people's pupils. Can you compare and contrast the new device to the older one? Is it faster, more accurate? What are the differences?
I don't know if it's 10 times faster, which is the biggest improvement. The original device, the first generation technology, which was called RapidX. I still got mine sitting in the garage if you want to buy one. I mean, it works. It's just slow.
Right,
It's slow, and you got about a 30-40% spoilage factor as opposed to 5%. Now, that means you got 60-65% good responses, and out of that 65%, you could get all kind of important information. But it took a while. It would take 4, 5, 6 minutes sometimes if people started blinking and going crazy. And so, if you got busy, it became a kind of an obstacle to your patient flow. To where you almost had to I almost had to just start using it like a test, where if I thought somebody had something wrong with them, I'd say, hey, go give me a pupil test.
right,
This is totally different. This thing is sitting on a table right next to the topographer, right next to the tonometer, right next to the autorefractor. It's part of the workup, and it's that quick. So it's just like doing an autorefractor, just like doing the pressure, a non-contact pressure. It takes about a minute. It actually takes longer to type the person's name into the computer than it does to do the test.
right,
Uh, and I actually told, I said, hey man, why do you got to do that? And they're trying to be all technical and doing it the right way where every test has the person's ID on it and stuff. So
right,
can you imagine doing an OCT scan without the patient's name on the printout?
right,
Okay. Well, you got to type the name in. Okay. So the biggest difference is that this one is fast, it's smaller, uh, it's better. It's just better. It's the same science, but much, much, much better. Think of these modern small perimeters we have, the doctors that are old enough like me, compared to the big giant car size ones that we bought back in the 90s, the big giant ones that took up a whole room. Okay, so
right.
they're just second generation technology. That's all it is.
Great. All right. Well, so we're just about out of time. So I'll get purely commercial now with everyone. So if you look at the slide up on the screen, Conan has extended webinar specials to everyone. So you can see what the list price of the device usually is and what the special is here at the webinar. So the only rule is you got till December 15th to qualify. They're also doing bundle deals as well, and you can ask for details, and you can see the contact information there up on the screen. If for some reason you lose it, you always know where to find me. So I can forward everyone's requests on as well. So definitely, if you're interested in this, you might want to take advantage of it by then. And that's about it. And one other thing, and I know that before we go, people always, we had a little raffle here tonight. So let me pull this out. It's funny, my dad's actually nagging me right now to do the drawing. So I
Am
promised him
I
I would.
am I eligible?
So this is the funny thing, right? I have a list of people who are not, and what's going to happen is the random number generator is going to pick one of us, I'm sure. So let me actually I'm going to run it down here. So let's see. Here we go. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 20, 28, 29, 30. And let's see if you're on the ineligible list. Okay, you're not my dad, so you're not. So Nancy Davis, you are the winner. of the Apple
Congratulations.
Watch. Congratulations. So yeah, I picked the number at random using a random number generator.
Oh,
So
man, you get to wear an Apple
congratulations.
Watch? Man, that's
It's an
cool.
it's an Apple Watch, yeah.
Oh,
So
yeah.
congratulations, Nancy. So I'm gonna ping you to try to get your physical address, and we'll get it on to you. So Craig, thanks so much for this tonight. This was a ton of fun. And if people have more questions, and they actually do, because I can still see them coming in, but we're kind of out of time here. Why don't we continue this thread on ODwire, and we'll keep the conversation going, because I have a feeling that this isn't going to go away. I have a feeling as it gets into people's workflow more and more, we're going to have a lot more to talk about on the site as well. So Craig, again, thanks so much for doing this
You're
tonight.
welcome. Like, I enjoyed it.
Great. All right. Well, thanks everybody for showing up, and I guess I'll see you all online.